Hello, my name's Michael. I'm one of the registrars working in virology at Addenbrooke's, and I'm going to talk about COVID-19 patient placement today. So the basic outline is this. Green wards are for people without COVID, amber are for people who have an uncertain COVID status, and red wards are for those who definitely do have COVID-19. When you're seeing someone in A&E or clerking them in, they need to be given a RAG rating, a red, amber, green rating, so we can decide where's best to put them in the hospital. If the patient you're seeing has symptoms of COVID-19, then they should be determined amber, at least amber, until their swab result is known. If their swab is then positive, then they can be called red, but until they have a positive swab, they should be amber category. Now, this includes any patient coming in with a fever, which will be a lot of the people you're seeing in A&E. They have to have a swab, which is negative before they can be said not to be in the amber category. Now, if people you're seeing don't have any symptoms of COVID and it's thought to be very unlikely, and there's an alternative diagnosis for what brought them into hospital, then they can be labelled green. Okay. Then what are you going to do when your swab result comes back? Well, if your patient has key symptoms of or features of COVID, then they will get a SAMBA swab and the results should be back in a few hours' time. If it's positive, well, then they've got COVID and they can be classified as red and be moved to a red ward. If the swab is negative, in the vast majority of cases, this means they don't have COVID and they can be labelled as green. However, if there's still a very high suspicion of COVID, or there's not a clear alternative diagnosis of what's going on, and it's still up there, right up there on our differentials, then they should remain in amber, either until they've had a further negative swab. Ideally, that would be a deep sample, for example, sputum, or until we have further evidence as to what's causing their disease. So chest x-rays, CT scans would be helpful in determining. And if it's uncertain, really uncertain, then discuss with virology about where it would be appropriate to place them. Anyone who is a COVID-19 contact has to remain in an amber bed for 14 days. That includes even if they were a contact outside of hospital, but when they come into hospital, they have to be isolated for 14 days. That's different from a 10-day isolation period if people are outside of hospitals, because in hospitals, we need to be more cautious about the potential for the late onsets, the longer incubation periods of COVID-19. And once a patient's had their bed status, that is where they'll stay unless things change. So if someone on a green ward develops symptoms of COVID, they should be assessed again. And if they have high suspicion of COVID, be put in an amber situation or put in a side room until their swab result has come back. And if someone on a ward develops COVID, their contacts are then COVID contacts and have to be in an amber situation. Red patients can be stepped down, and this is the national guidance which we're following in our trust. You can step them down at 14 days if they've had clinical improvement, and this includes at least some respiratory recovery. They have to be fever-free without the use of medication, and they have to have no underlying severe immunosuppression. And I'll talk about that group later. So if your patient fits that criteria, they may be stepped down and they don't require another COVID-19 test to set them down. You don't need a negative test to say that you don't have COVID. In fact, it's quite well known that patients with COVID may continue to shed non-infectious RNA for long periods, for weeks after they've recovered from the infection. So doing swabs on these and getting a positive result probably just means nothing and can be ignored. Now, this testing criteria includes patients going home to nursing homes if they've previously had COVID and completed their isolation and improved, then they don't need a COVID test prior to discharge. That's according to the national guidelines. Now, clearly, there's a big caveat in this step-down pathway for those with severe immunosuppression, and quite a few of the hospital cohort may be included in this group. This slide shows some of those. For the full list, check the patient placement guidelines, which is in the COVID document library with a quick link on the right-hand side of the page when you're on the document library. And this is taken from the Green Book. And this includes quite a few patients, lots of hematology patients, anyone with leukemia, lymphoma, or chronic lymphoproliferative disorders, cancer patients, anyone who's had chemotherapy or radiotherapy in the last 6 months, any solid organ transplant patient on immunosuppression, rheumatological patients who have had biologic therapy within the last 12 months, people who have genuine underlying immunodeficiencies like cellular immunodeficiencies, or people who have HIV with a low CD4 count. And the last group, which will include quite a few in the hospital, is those who've been treated with immunosuppressants, including prednisolone. So if you've had over 40 milligrams of prednisolone a day for over a week, you're included as severely immunosuppressed, or a lower dose for 2 weeks, so over 20 milligrams a day for 2 weeks. Please check the full list to see if your patient would be included in those. If your patient has severe immunosuppression, our trust has decided that we would like to keep the patients in a red ward for 20 days. And after 20 days, if they have improved, to consider stepping down to an amber ward. But there remains quite a lot of uncertainty about the duration of infection in these patients and whether they still are infectious with viable virus at great and longer time points than this. So at our trust, we're saying keep people in the minimum at an amber bed after their infection. If patients have been readmitted to hospital having previously had a test and they've recovered from their initial illness, then they can be treated as green, and there's no need to retest anyone who's had a previous positive result within 90 days of that previous positive result. And that's because of the likelihood of residual RNA shedding, as I described earlier. If patients come back in with new symptoms of COVID-19, then they should be re-swabbed again, regardless of their previous results, because there can be cases of reinfection, particularly in those who are immunocompromised. However, if someone's coming back in again and they previously had COVID and they're in the severely immunocompromised group, they should be automatically put in an amber bed, as I just discussed earlier. For more information on this, see the patient placement guidelines, particularly pages 6 and 7 for the red step down and readmission, or contact virology if you've got any particular concerns or any difficult questions to answer, and we can try and help with those. Okay.